Everyone, thank you for joining today's call. This is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Today's presenters are Dr. Dimitri Daskalakis, Deputy Commissioner for the Division of Disease Control, and Dr. Mila Harrison, Assistant Commissioner for Mental Health. Please note that you have all been placed in listen-only mode. If you have any questions during this presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. As a reminder, a PDF of these slides, as well as a recording of today's webinar, will be available on our webpage following today's presentation. We appreciate that you all are busy doing important work and appreciate you spending part of your afternoon with us. Without further ado, here is Dr. Daskalakis.
Good afternoon, everyone, and thank you again for joining us for a healthcare provider update on COVID-19. I'll remind you our normal disclaimer, which is that our understanding of this novel coronavirus is evolving rapidly, and our presentation is based on our knowledge as of April 17th at 12:30 p.m. So just a quick outline of our presentation. So I will go through current status of the outbreak and some New York City surveillance data, start with some clinical findings, and I'll pass off to Dr. Mila Harris, who will take over for discussing behavioral health responses. Then we will have some open time at the end for questions and discussion. So where we are, there's still widespread community transmission of COVID-19, both in New York City and around the world. It is hard to believe, but really it has been 7 weeks since we had our first reported confirmed COVID-19 case in the city. We are still seeing high numbers of new diagnoses, including individuals who require hospitalization. But we do have the beginning of some good news, though I caution you that we need to be very careful about it. Important to sort of watch what's happening, but really be clear that though it looks as if that we've begun to flatten the curve, we need to have a lot of caution and really guarded optimism. So our syndromic surveillance data shows improvement in emergency department visits and admissions, really one of the more sensitive markers for what's happening in the COVID-19 outbreak. We cannot let down our guard, but really at the end of the day, despite this good news, must reinforce mitigation measures that are working. That means physical distancing and all of the other aspects of putting New York City on pause. COVID-19 continues to be a significant outbreak across the globe. There's over 2.1 million cases, and unfortunately, there have been nearly 150,000 deaths. This is a view into our syndromic surveillance. So just to remind you, emergency departments on a very routine basis, sometimes many times daily, push data over to the Department of Health about what they're seeing in their ED. And so what this slide shows is influenza-like and pneumonia emergency department visits per 100,000 people. And it looks at it through the eyes of age. So you'll see that there's different categories, 0 to 17, 18 to 44, et cetera. The big news on this slide is that no matter which age category you're looking at, all of them are down, which means that fewer people are coming to the emergency room complaining of influenza-like illness and pneumonia. This is another view which focuses on admissions. And this is the same idea, so information being transmitted to us on a very routine basis from emergency departments, showing that for the most part, there is a trend in decreasing influenza-like illness and pneumonia emergency department admissions to the hospital. Again, this is some early indication that we potentially are flattening the curve. Now, we continue to see a pretty significant amount of activity of COVID-19 across the United States. This map will remind you that we are the epicenter of this activity. We have seen in the US over 673,000 cases, and again, unfortunately, over 30,000 deaths. So let's look at New York City. The current status of the New York City outbreak is that we've had 117,565 laboratory confirmed cases. So that's an important distinction. So there are folks who are not getting tested, both because of our guidance that really focuses individuals on testing only hospitalized individuals, and also on some of the scarcity of tests, as well as the personal protective equipment required to obtain them. So that means that there's more than 117,000 people in New York City who have had COVID, These are the ones who've had positive tests. In terms of those hospitalized, our data show over 30,000 people, almost 31,000 people have been hospitalized. And we have started reporting our deaths in a different way. So we have 7,563 confirmed deaths that are in individuals who have tested positive for COVID-19. Additionally, we've identified 3,914 deaths among individuals who are probable cases of COVID-19. So we'll talk more about what that means. But again, just briefly, confirmed cases means test positive. Probable cases means the death certificate said that they had COVID-19, whether they were tested or not. So this is a view into our city and the total case counts throughout the jurisdiction. So you'll see, again, where we're seeing our highest number of cases. The darker purple represents more cases. Another view into this is the percentage of patients testing positive for COVID-19 by zip code. So you'll see among tests that were obtained where they're more likely to be positive. Again, darker purple means higher positivity rate for COVID-19 cases, so more positive tests. Now, on our website, you'll also see these in a very dynamic graphic way. It is a view into New York City COVID-19 cases, hospitalizations, and deaths over time. So I'll remind you a couple of things. So there's always a lag. So at the very end of these curves, you'll tend to see low bars, and it feels like it's good news. We hope it'll be good news, but really it represents a lag between when cases get diagnosed, when labs are reported to the Department of Health, same with hospitalizations and deaths. So there's a built-in lag. So don't believe those low bars at the end yet. So it's important to note something very interesting when you look at our death rate, which you'll see that cases peak and then actually deaths lag 1 to 2 weeks behind the cases and hospitalizations. So that just really reflects the fact that people don't get COVID and necessarily succumb to it right away. That in fact, there's a lag between getting infected, getting sick, and then ultimately succumbing to the infection. We also have a view on our website as well of New York City case rates by borough. It indicates it indicates the rates of COVID in various parts of the city. So you'll see that although the actual counts are low, the rates are highest in Staten Island, followed by the Bronx, Queens, Brooklyn, and Manhattan. Available on our website as well, you'll be able to find these graphs, which demonstrate case counts, hospitalizations, and deaths, and really stratifies it according to gender. Now, I'll give you my apologetic here, which is that we do not show anything but a binary gender marker, because these are lab reports, and very often gender other than male or female is not often shared on those lab reports. So this really focuses on a binary, and I apologize in advance for that limit. So I hope someday our labs are able to report better on gender identity. But ultimately what you see is that cases, hospitalizations, and deaths are more common in men. So in terms of our death surveillance, I already spoke a bit about that, but we know that not all persons infected with SARS-CoV-2 are diagnosed by laboratory confirmation. So routinely, we capture deaths for laboratory confirmed COVID-19s by finding out who passed away in our jurisdiction and matching it into our registry to demonstrate who had a positive test for COVID-19. Now, that doesn't capture everyone. It misses the individuals who are probable. So to capture deaths for probable COVID-19 cases, there is a very thorough review of death certificates. And then we also look at excess mortality compared to expected mortality. So ultimately, though very somber news, it's really important that we count all New Yorkers who have experienced this outcome of COVID-19. This graph is another way of showing what I just said to you. So you'll see that there are COVID-19 deaths that are marked in orange and in blue. The orange represent confirmed and the blue represent probable. So again, that gives you a better view into the impact that this horrible virus has had on our city. Additionally, it's really important to realize that beyond age, there is also the issue of comorbidity. So underlying conditions such as lung disease, asthma, heart disease, a weakened immune system, for one reason or another, obesity, diabetes, kidney disease, liver disease, and cancer confer a higher risk of death in individuals who get COVID-19. So you'll see that among total deaths, the observation is that older individuals are at higher risk. So individuals who are at risk, really risk increases around the age of 50, but the individuals at the highest risk are those who are over 65. And if you are over 75, you can see again, really overrepresented in the death count among cases of COVID-19. You'll also see that underlying conditions really interact a lot with COVID-19 and the possibility or the risk of death. So you'll see again that the vast majority of individuals with underlying conditions, the vast majority of those who died of COVID-19 had underlying conditions. Now, it's important to remember that the older you get, the more likely you are to have some of those underlying conditions. So we'll have to be able to tease that out with further statistical analysis. But older age and comorbidities are clearly a risk factor for a worse outcome for COVID-19. This is another view that shows COVID cases, hospitalizations, and death by race or ethnicity. If you were following our presentation or our website last week, Hispanic and Latino individuals were at the highest risk of hospitalization or being a case, being hospitalized, or having passed away. So with more complete data, now that we have 88% of data on deaths and 72% on hospitalized, we are now reflecting the trends seen in the rest of the country, that Black or African-American individuals are at highest risk for both being a case, for being hospitalized, and for mortality. So really sobering and really raises the importance of ongoing work that the Department of Health is doing and all of you are doing to make sure that we are keeping an eye on equity as this pandemic looms in our city. So in terms of death reporting, report all deaths occurring in New York City to eVital through your facility administrator. You can also email evital@health.nyc.gov for facility permission, and you do not have to report deaths to us by phone, not necessary. I also want to give you a very important warning about some testing. So there's a lot of news about serological assays for SARS-CoV-2. So we caution you, both providers and clinical laboratories, of a couple of things. There are unvalidated SARS-CoV-2 serology testing kits out there. You should not use them. There's also some that have false advertising as being approved, and they may not be reliable. So for instance, there is no approved point of care serologic test for SARS-CoV-2. So over 95 companies have informed the FDA of the intent to distribute serology tests for this virus in the US marketplace. Problem is, sensitivity, specificities, and predictive values of these serology kits have not been evaluated by any individual government agency, including FDA. Good news is there are more antibody tests coming out soon, and they will be better. But always remember that a positive serologic test for SARS-CoV-2 does not mean that someone is immune. We don't know the answer to that question. So a positive antibody does not absolutely equal immunity. It's and there will be an upcoming health alert that will remind you of this. False positives and false negatives results can occur even if test kits have been evaluated. So no CDC guidelines for interpretation of serology tests exists. So using a test inappropriately in point of care or moderate complexity laboratory settings may put your practice out of compliance and could result in regulatory action. So really be cautious about the testing that you're using. And again, though it may not be anyone's fault, there is a lot of false or incorrect advertising around this. So please, if you have any questions, feel free to reach out to us. Now, another important issue is that testing continues to be challenged by supply. The US, as well as the rest of the world, is experiencing severe shortages of swabs and viral transport media. There's severe shortages of both nasopharyngeal swabs and that pink fluid in the plastic vial or viral transport media that's necessary, at least at this point, to diagnose COVID-19 using a PCR or molecular amplification test. As supplies continues to decline, it's a real possibility that hospitals could run out. So at this point in the pandemic, and we hope that we're going to change our guidance, but at this point, providers should continue to test only hospitalized patients to preserve resources that are needed to diagnose and appropriately manage those with more severe illness. So we are working actively to mitigate current barriers to testing. And the good news is New York City as a whole is working very actively at alternatives and also finding other strategies to um, access the testing supplies necessary to do this screening. I want to briefly go over a face mask policy for healthcare workers. Healthcare workers and staff who work while asymptomatic pose a risk to patients and each other. To reduce the potential risk of asymptomatic transmission to other staff and patients, all healthcare facility staff should wear a mask regardless of type of setting or service being provided. So follow guidance from the healthcare facility regarding what type of face mask to wear, but ultimately, if you're in a healthcare setting, we think it's the right answer to wear a mask for now. Again, it's less to protect yourself, but it's more to protect others. So think about it like your staff members who don't get the flu vaccine. There's a mandate that they need to wear masks while they're at work. So this is the same theory, that even though you are asymptomatic, even though it's source control, for the possibility that in a couple of days before symptoms, that we're not accidentally transmitting to our patients. So wear masks when you're in a healthcare setting. Additionally, there's clear guidance about face coverings for public in New York City. So the guidance is that all New Yorkers must wear a face covering when in public if they cannot maintain physical distancing. Now that excludes children less than 2 years old and people who are unable to medically tolerate it. Like if they have chronic lung disease and they just cannot wear a mask, they are allowed not to wear one. There's also a governor's executive order number 202.17 that came into effect on the 17th, or is coming into effect on the 17th at 8 p.m. So it's important to remember that this is now a requirement. Now, what is a face covering? That's a well-secured paper or cloth covering that covers one's mouth and nose. So currently I'm giving you a talk wearing a bandana because I'm not in a healthcare setting. I'm surrounded by others in the room who are also wearing bandanas and they're about 6 feet away from me. So we're in a good place. It's also important to remember that this is about source control and reducing the potential risk of asymptomatic transmission. So it's really important still to stress all the physical distancing and all that good hand hygiene and good coughing and sneezing hygiene that we've been talking about since the beginning of this pandemic. We continue to have alternate care sites stood up in New York City. So you'll see some pictures of the Javits Center and then also the Navy ship USS Comfort coming into port. So there are, again, many locations where we have alternate care sites to really help decant hospitals so that we have more room for people who are coming in. So these will continue to serve patients and are really important piece of the response to this pandemic and really represent great teamwork between the federal government, the state, and the city. Now, we often get questions about therapeutics for COVID-19. I want to briefly cover the use of remdesivir for patients with severe COVID. There are still no proven meds for the treatment of this virus. There are trials of a variety of different medications that are currently underway. So a recent study of remdesivir used for hospitalized COVID-19 patients who had an oxygen saturation of less than 94% while they were breathing ambient air or receiving oxygen support should have benefit in most patients. So 36 out of 53 or 68% had improvement. There was no randomized control group and evaluation of efficacy is therefore limited, but a glimmer of hope. Now, another important notion is really the role of public health interventions in changing the epidemic. So this is a graph that demonstrates RT, which you may have all have heard of R naught. This is a similar number that demonstrates how infectious a virus is, how it transmits person to person. So what you'll see is that early, without strong interventions, the infectiousness or infectivity of the virus was high. When mitigation began, it started to lower. And then ultimately, when they put their city on lockdown, what you saw was that the RT decreased rapidly. And what's really important to remember is that number one is very important. So an RT or not of one means that that for every person infected, they transmit to one person. When that goes under one, that means that an outbreak can extinguish itself because it's not transmitting effectively. So the higher that number, the worse it is. So you'll see why mitigation strategies, such as those that we're doing now, are so critical in bringing this pandemic under control. Now, what would be even better is a vaccine. We don't have one yet. So in the absence of a vaccine, these other more physical distancing interventions are critical in changing the story. So let's talk about the impact of physical distancing. We currently have a limited set of preventative measures for COVID-19. Like I said, no vaccine, and we have no treatment. So physical distancing is one of our main tools. So recent data from CDC show that our efforts to promote physical distancing in New York City have likely been effective at reducing community mobility, and this in turn has likely reduced the spread of the virus. So this is a graph that's fairly complicated, but you can see that what it shows is arrows of where various things have happened in New York City. And what you can tell, what you can look at from the perspective of the case count, as well as what is happening with the percentage of people who are leaving home. Like ultimately, you're seeing that you're having a decrease in case count, and that really is what we're looking for. Where ultimately our goal is to see the curve slowly reducing. So in terms of health implications of physical distancing, a survey of adults in multiple cities in China during February 20 to 21st, 2020, this was done. Those who stopped working reported worse mental and physical health conditions and distress. Data such as these emphasize that the impact of COVID-19 actually is significant, even in those who may not have been infected by the virus. So I think for those of us who are living in New York City and are sort of living through social distancing and what it means to work from home and not have the normal interactions that we have, this isn't surprising data, but really makes a very clear point that there's more impact to social distancing than to just flattening the curve. So we're really trying to figure out strategies and have offered some to what we can look toward for when we can start loosening our physical distancing. So we're monitoring closely key public health signs to determine when physical distancing restrictions can be loosened for people not at high risk for serious COVID-19 illness. So we are closely following three types of indicators: hospital admissions, critical care capacity, and positive test rates. If you want to see these, you can go to our website and look for our public health milestones so you can see the latest indicator data, which we update daily. So this is an example of our testing indicator. The blue line represents testing at our public health laboratory, and the orange line is all New York City testing. And we have milestones that we want to achieve to be able to get to the point where recommendations can be made to start pulling back on some of our social distancing or mitigation strategies. With that said, these are important indicators, but they're not the only part of the story. These are just really good signs that we're going in the right direction to potentially bring New York City back. And with that, I will give the mic over to Dr. Mila Harrison.
Thank you so much. Hoping you can hear me. Good afternoon, everybody. I'm going to be talking now about...
Dr. Harrison?
Yes. Can you hear me? Can you
Dr.
hear me?
Harrison, if you're on mute, we can't hear you.
I am not on mute, and I'm trying to talk. So can you hear me now?
I can.
Yeah.
Okay, wonderful. Thank you. I'm not on mute, so good. I'm glad you can hear me. Okay, so what I'm going to be talking about is the health department's response from a behavioral health perspective during COVID-19. And I'm going to have the slides advanced for me. Can you please advance? So as part of this response, we have a mental health emergency response group. And our group is responsible to being attentive to the behavioral health needs of New Yorkers during this pandemic and of anticipating and planning for the behavioral health needs that are going to follow this pandemic. In particular, we have goals that we like to focus on and objectives, and that is to share reliable information and resources, to collaborate with our behavioral health partners across the city, to strengthen existing resources so that we're responsive to the needs of New Yorkers. And we've been strengthening NYC Well, which I will be talking quite a bit about today. And we are promoting coping and resiliency for all New Yorkers. Next slide. So the messages that we have been really talking about are around coping and mental wellness. And I'm going to go into more depth on these three areas, but specifically, it's important, excuse me, when we're dealing with crises like these, emergencies like these, disasters such as this pandemic, it's important to normalize symptoms of stress, anxiety, and grief that we all go through. We also find it critical to promote information about coping and promote our ability to be resilient in these sorts of times. And we are also making sure that resources are available for when additional support is needed. And we have calls to action about how to get those resources. And I'm going to be talking about with you today. Next slide. So let's start with normalizing symptoms of stress, anxiety, and grief. Stress can impact the way you think, feel, and act. And most of the effects are normal reactions to distressing events and are generally short-lived. So for instance, physical effects of stress include fatigue, exhaustion, headaches, having a rapid heartbeat, or even exacerbation of pre-existing medical conditions. Emotionally, during stressful times, people can feel sad, anxious, angry, agitated, and irritable. Some of the mental effects of stress and anxiety include confusion, forgetfulness, difficulty concentrating or making decisions. And then we also see behavioral effects, and that could be experiencing uncharacteristic behaviors such as becoming restless, argumentative, short-tempered, or even finding changes with eating and sleeping patterns. Next slide. So what we want to do, in addition to letting people make sure they're aware of the kinds of symptoms you might feel when you're stressed and anxious, we want to be able to help people cope and be as resilient as possible in these times. And in order to promote coping, it's important to stay informed. So for all of you who are calling into these sessions, you are informing yourselves about what's going on in New York City, and that's important to do. It's also really critical to limit screen time and exposure to media. And some folks say, perhaps, don't turn on the TV or look at the news related to coronavirus more than a couple of times a day. It's important to stay connected, and when we stay connected, we mean to friends and family and colleagues and coworkers. Even more critical now that we are being asked to be at home, and essential workers are being asked to not necessarily be at home, but really more important to stay connected. It's critical to create and maintain daily routines so that even in this time, people are waking up at regular times, eating meals at regular times, going to bed at regular times. Those can help with coping and resiliency. It's important to stay positive, as well as to focus on the things that you can control and to be proactive any time you can. We want folks to be thoughtful and sensitive, and this is really about the stigma that we've been hearing about that certain communities are facing around COVID-19. We need to have no excuse for stigmatizing people and not tolerate it. This last bullet is about sharing with you the NYC website, which offers wellness and emotional support applications for people to use that can help them cope. And there is a link at the bottom here. And on the next slide, I'm going to share with you how to get there. Next slide, please. So when you go to the NYC Well page, which you can put into any search engine, at the very top of the page, there's this red arrow showing you that if you click there, you will be taken to a list of free apps, free mental health apps that are available right now during COVID-19 pandemic. There are other apps on the website that also have a free aspect to them, but we've been able to increase the number of available apps. The next slide shows you, and the link is on the left side of the slide, but this shows you a sampling of the free apps that are available right now. And so, for instance, for yourselves or for patients or colleagues, the first app here on the left under anxiety is Headspace. And Headspace is an app that has meditation resources, for instance, and can be used specifically for people who want to be able to focus and have some mindfulness activities for themselves. And there's many other apps you can see here as well. Next slide. So what I want to talk about now is the additional resources that are available for anyone in New York to be able to access, if indeed using apps, doing your own mindfulness, staying connected isn't really helping enough, and you need to reach out to other people. So NYC Well is our New York City call, text, and chat line. It's available 24 hours a day, 7 days a week. Is available to New Yorkers who need to talk to somebody, who need to text someone. It offers telephonic counseling and as well as referrals to care in multiple languages. And indeed, if you just want a referral to care and just want to be able to know who to connect to without talking to somebody, you can go on the website and you can access their resource directory. And the phone number is here, 888-NYC-WELL, or you can text WELL to 65173. There is also a chat component. That's what New York City has to offer. The New York State has recently put up an emotional support helpline that is supported by trained volunteer professionals, and they are available 8 a.m. to 10 p.m. 7 days a week as well. I'm giving you more than one resource because we have actually had a lot of traffic to our NYC Well site, and you might have to wait a little bit longer than you used to because of the volume of traffic to it. So I'm giving some more than one resource, but we like the idea of a one-stop shop for folks, and that's why we're promoting NYC Well so heavily. Next slide. This slide is showing you the volume of answered contacts by NYC Well in the previous 6 weeks up through the week ending April 12th. There is a dotted green line, horizontal line that shows last year's average answer contacts, which was in the 5,000 range. And in the prior 3 weeks, we have had calls, texts, and chats that have been quite a bit over the average from last year. And so the volume to the call line is not expected, is higher than usual, and that is not unexpected in a time of crisis like this. Next slide. So the other information that we want you to know about is the health department's own resources around coping and emotional well-being. We have a web page, and in a minute I will show you how to get there, but we have a web page where you can actually access a lot of guidance documents. And the guidance documents we've been creating have been responsive to and anticipatory of the community's needs. We are keeping them in relatively plain language with accessible information, and we update it regularly. And the content and priorities have been informed by our own expertise and our own epidemiology, as well as requests from providers, the community, the press, and what we know about disaster and outbreak response best practices from previous events. Next slide. So there's a number of ways to get to the coping and emotional well-being section of the health department's website. One way, if you are on just the nyc.gov side, there is a way to follow the link, follow to the NYC Health Department, but you can also click on resources for New Yorkers. There's a red arrow here pointing to that. And if you click on that, the next slide will take you to another screen, which has information that says health and emotional well-being, and the red arrow is pointing you to get tips and information about coping and emotional well-being. And the next slide shows you an image of what that page looks like. So on the left is an image of the page that's coping and emotional well-being. And it's hard to see here and not meant for you to see clearly, but there are tabs on the left side of the page, and you can see coping and emotional well-being as one of the tabs as well. Documents that are currently available, and I can tell you this has changed since we created this slide yesterday. We've added some more documents that have been put up. But the kinds of things that we have available are guidance around coping with stress during an infectious disease outbreak, guidance on is it anxiety, a panic attack, or COVID-19. This is one of our most commonly downloaded document. Grief and loss during the COVID-19 outbreak, staying connected with family and friends and family, managing grief over the death of a loved one during the COVID-19 outbreak, and information for people who use drugs. Those are some examples. We have others as well. And there is also a curated list at the bottom of our page that has additional resources from national organizations and other government agencies, both on general resources, specific things for children and families and educators, for community leaders, and for responders and healthcare workers. And again, the page link is on the bottom of this slide. Next slide. So in addition to having a web page, it's really important that we promote this information so the public and healthcare providers are aware of what is out there. So through social media, there have been behavioral health content that's posted a couple of times a day on various social media platforms, such as Instagram and Twitter and Facebook. The call to action has been pointing people to our coping and emotional well-being page, where there are many documents I pointed out, or to our NYC Well content, which is depending on what we are saying in the message. In addition, we've been highlighting other virtual resources, such as the apps that I showed you earlier, and ones that are free and the ones that are up on the NYC Well website as well. In addition, there are other virtual resources that we've been highlighting. So for instance, New York City Health and Hospitals has a virtual buprenorphine clinic, and that has been highlighted on some of these pages. I want to say, we can move to the next slide, where I wanted to share with you information about a media campaign that's up now. We created this in collaboration with the First Lady of New York City, and the campaign is around coping with stress that's brought on by COVID-19 and physical distancing. And the campaign is a way to normalize symptoms, ones we've been talking about, in addition to stress reduction strategies, and offers information on how to contact NYC Well for emotional support and resources. This campaign has citywide distribution. Our next slide is some screenshots from the campaign. It's called New Yorkers Stay Home and Stay Connected. And you can also, it is on TV and on local network TV, but you can also access it on the NYC Health YouTube account. It's a 1 minute long campaign. Next slide. So we've also, are very aware that we've been putting out a lot of information for the public, and are also aware that although all that information is specific to everyone, there are additional resources that healthcare workers need in this particular time. And so on our website, there is also tips for healthcare workers that's called Taking Care of Your Emotional Well-Being. It's on that same website I just shared with you a few slides ago, Coping and Emotional Well-Being. And in this, pays more attention to your own needs as healthcare workers, your own anxiety and stress about being at increased risk if you're exposed to patients, and the risk to yourselves and your family. So it addresses those issues. We will be putting into one of our next Dear Colleagues letter the same kind of information about recognizing and addressing behavioral health issues during COVID-19. And we recently put up a grief and loss in the workplace guidance document as well on our website. So these are specific resources providers can use for themselves. And yet all of the other resources are equally useful to providers and the community, the public, the patients you may be serving. Next slide. So what are we doing in addition to talking about how we cope now? We are already thinking about the ongoing behavioral health impact and how to plan for it. So we are promoting mental wellness and healthy coping to encourage resiliency going into the future. And we can't stop with just what we've been talking about now. We know this is going to go on, and we need to make sure people can cope as best as they can. We know from prior disasters that ongoing negative behavioral health impacts may be seen for some New Yorkers, and we therefore want to be able to anticipate that need. We want to make sure we've got available behavioral health screenings and support and treatment for some time to come. So we are engaging in that conversation right now and how to plan for that. The next slide I have is a slide we have gotten from Twitter from a pulmonary and critical care physician who's spoken about the psychological impact of disasters. I put this slide up not to share with you what he has here as the waves related to illness, physical illness, but to share with you this red line that's called the fourth wave, which is the psychological impact wave of a disaster. And that this is showing you that increasing over time, we will likely see increased psychological trauma, mental illness, alcohol use, injury that's economic, that has already begun, and healthcare worker burnout, which we really want to be aware of and guard against. And so, as I mentioned earlier, we are preparing now for the later effects that we generally know we're going to see following a disaster, and want to be able to have people coping as well as they can and being as healthy, as mentally healthy as they can, so that they can continue to take care of patients. Next slide. So I'm going to pass the mic back to Dr. Daskalakis.
Thank you, Dr. Daskalakis and Dr. Harrison, for that important information. We do have some time remaining for Q&A, so I just remind everyone to go ahead and enter any questions they have in the Q&A chat box or the text box. As always, the most common questions we've gotten so far have to do with where these slides will be posted and if they'll be available. So just as a reminder, they will be available on our provider webpage. We also have gotten a few questions about the Dear Colleague letter, which is also available on our provider webpage and is distributed via our CHI distribution list. So if you want to be sure that you get future iterations of the Dear Colleague letter, please be sure that you are signed up for our CHI. To get us started, we have a few questions that came in early about serology and specifically, so can serology tests be used in practice, and how should they be used in public health?
So as there's really two main roles for serologic testing. So first, let's talk about the tests that are available. That's probably a really good start. So currently, there are only 3 tests that have received emergency use agreements from the FDA, and all 3 of them have one major issue in common, which is that they all have a cross-reactivity with the common coronaviruses. So remember, coronaviruses, not just this coronavirus, but a lot of other coronaviruses that may be consistent, maybe more associated with colds. And so because of that cross-reactivity, I would say we have to be very cautious with how we interpret a serology test. Now, people may ask for serologic testing, and you can choose to do it, but what's really important is that the guidance is that this test may imply that you have been exposed to COVID-19, but it does not prove immunity to COVID-19. So what it really is important for in general is potentially for individuals who want to donate plasma for some of the really great studies going on now for convalescent plasma donation for people who are ill to see if it can sort of function as a therapeutic. It also has an important role in public health because we will be doing both here, internationally, everyone is going to be doing serosurveys, which are sort of samples of individuals in the community to see if they've been exposed to COVID, just to see how much of COVID was really out there. Again, remember, we don't have the full picture of COVID because we're only diagnosing some people because of some of the scarcity that we've had with testing. So if you do order a test, always remember to know how that test works. And so there will be other tests that will be coming out that will have less cross-reactivity or potentially even no cross-reactivity with other common coronaviruses. So that's really good news. No matter what, though, that test can't be used as a marker of immunity because we just don't know enough. So at this time, the test is more a marker of exposure and shouldn't be thought of as a marker of immunity.
Great, thank you. On a somewhat related note, we have questions about testing of healthcare workers and non-essential of essential workers before sending them back to work. What is our guidance on that?
So we will have clear guidance. The guidance, at least right now, unofficially, is exactly as I said before, that this testing is a good marker of exposure, but does not replace PPE or social distancing as a marker of immunity. So we shouldn't use antibodies to replace 6 feet of distance, nor should we use antibodies to replace PPE. I'll give you like an example. So there are certain viruses that we know if you have a positive antibody that you may be immune to. And so my favorite example is measles, having had just lived through a large measles outbreak. I'll tell you that measles serology is pretty reliable. And if you look at how measles serology is reported, it's reported as immune or not immune. And that comes from a lot of studies demonstrating like what the cutoff is to be able to define immunity. Now, we don't have a cutoff for coronavirus, so I don't know what level of immunity is going to give you coronavirus immunity. But I'll remind you that even with measles immunity, we had cases in individuals who were immune. So immunity is not 100%. So when you think about when you are in a clinical setting and you know that you're immune to measles, if you're going to see someone who's potentially a measles patient, you still wear all the PPE as if though you don't have immunity. That reason is that nothing is perfect. And so again, even measles, where we have a really good test for immunity, we aren't really always 100% to the point where we send someone into a setting without appropriate PPE. So coronavirus is similar. Now, we really don't know what a positive coronavirus antibody means. We still need to learn that. Does it confer temporary immunity? Does it confer any immunity? Does it confer immunity for a short amount of time? We don't know the answer, so we shouldn't chance it. So the answer is that the testing can be used to help people feel better that they've been potentially exposed to coronavirus, but it shouldn't replace our very clear guidance for personal protective equipment and physical distancing.
Thank you. Another question about testing. Do point of care test results need to be reported via eclairs?
Repeat the question.
Yes. Do point of care test results need to be reported via eclairs?
So automated lab reporting means that it comes to the lab. So I mean, ideally, we would love to know about the point of care test, but at the moment, I don't think that they're required to go through eClears. We'll circle back to double check, but they probably don't even have a mechanism for going through eClears because they're going to be reported for the most part in your electronic or physical medical record. And also important to remember, no matter what, there is no point of care serology, nor is there a point of care there is a point of care PCR approved actually, but there's no point of care serology approved. So if you're running a point of care serology, that's not one that is authorized to be used by the FDA.
Great. We have a few questions about children, specifically children as potential vectors of transmission. Do we have any data or do you know anything that indicates whether or not children are efficient vectors? And if we don't have the information, what kind of studies should be done to analyze that?
Great. So great question. So I think what we do know in the jurisdiction from the epi perspective is that there are not a lot of kids who get very sick, as far as we can tell. And so I think it's possible that children have mild disease. And if it's like other respiratory viruses, such as the flu, it would not be an impossible thought that they're potentially a really good vector of transmission. So I think we need to learn more, look at our epidemiology, see if there are studies of asymptomatic carriage in kids. All of those things that come together could potentially tell us more, and eventually also, molecular epidemiology that would look specifically at viral transmission could also be suggestive. So we have a ways to go, but in terms of what we see in the community and what we're seeing in our epidemiology, it seems as if children, when they have this, do not have a very significant or potentially very symptomatic illness.
Thank you. We have a question about the alternate care sites. Is the city health department or the state health department collecting data on outcomes at those sites?
We're all collaborating together, city, state, and federal government. So we all are working together on the outcomes in those sites.
And I will say that some of the alternate care sites are under sort of different management. So there are several that are basically being run as an extension of their partner hospitals. So any data that would be, so they'd be included in any data reported from those respective hospitals.
Thank you. We have actually a couple of questions about any additional information on the transmission of COVID-19 through fecal matter.
So COVID-19 has been detected in feces, but we don't think that that's a primary mechanism of transmission. This is a respiratory virus, and for the most part, transmission appears to be respiratory. So with that said, I think more to come, and the more we learn, the more we learn about this virus. So I think from the perspective of precaution, I think again, when you're dealing with a patient, remember to always be in appropriate precautions, and specifically that means contact. If you're doing aerosolized procedures, an N95, in normal care, a regular mask is fine, and also some kind of face guard. So ultimately, that full PPE is really important. And again, the jury on the efficiency of transmission through fecal oral transmission is still out.
And one thing to add to that, there have been several that have shown a high rate of positive PCRs in restrooms and toilets. So just again reemphasizes the need.
Thank you. And I failed to mention earlier that we have also been joined by Dr. Mary Foote, who is our healthcare systems planning lead for this outbreak response. So thank you for joining us, Dr. Foote. Another question we have here is about can someone get a second infection after they have recovered from COVID-19? What do we know about that?
Yeah, so really limited data, which is why we caution against interpreting serologies that are positive as evidence of immunity. So I think that there's reports out there, and again, since we don't really know the answer, there have been reports. There was one recent one from Korea. There's some from China of individuals who they report as reinfected. I think to really demonstrate reinfection, it's pretty significant endeavor, and so you need to know really the sequence of their virus before, and then the sequence of the virus after what is called a second infection to see what's happening. So I think, again, the jury's out. We're not going to know for a while until those studies are done. So we should act as if a serology, an antibody test, is just evidence of possible exposure, especially if it's one that has less or no cross-reactivity, which at this point is none of them on the market. But I think we should act as if it's possible to be reinfected until we know better.
Thank you. We have a question here about remdesivir and specifically whether it is currently available outside of a clinical trial for compassionate use or for women who are pregnant or children.
Dr. Foote, you can correct me, but my recollection is that they've actually have stopped doing the compassionate use program, so it's only available in studies.
Right. Yeah. Due to supply chain issues.
Yeah. So that's a correct. Yes, only available within the study.
Great. So just a reminder to everybody, thank you so much for joining us today. These slides will be available online as a PDF as well as a recording of this webinar. We also just want to remind you that this webinar will be held again next week on Friday at 2 p.m. Registration will be available on our webpage also. So thank you all for the very important work that you're doing. And we look forward to chatting with you again next week. Thank you.